Thank you very much for joining us for this webinar. My name is Dan Treiman, and I'm the CEO of NEIBC, which stands for New England Israel Business Council. We are a not-for-profit organization with the primary mission of facilitating and managing the business relationship between Israel and Massachusetts. Before I start and introduce the speaker today, I would like to introduce Sagit Sadeh Atiya. She has joined me in producing the series of the 3 webinars, and she's going to manage the Q&A session following the presentation. If you have a question, please use the chat button and the questions will be answered at the end of the presentation. With that, I would like to introduce the speaker today, David Baron. David is a co-founder and a principal at Boston MedTech Advisors. David has over 35 years experience in healthcare, including management, both technical and operation, strategic planning, marketing, and business development. Currently, he's focusing his activities on advising and assisting U.S. and offshore medical technology organizations ranging in size from startup to Fortune 500. The areas that he's focusing in are opportunity analysis, marketing strategy and market development, reimbursement strategies, and business development and financing. Prior to co-founding BMTA, David held senior management positions in a number of medical device companies and has founded, financed, and developed a number of healthcare companies. David received his graduate degree in biomedical engineering and his MBA from Rensselaer Polytech Institute in New York. And with that, I would like to invite David to the podium. David, the podium is yours.
Dan, thank you very much for the kind introduction. I'm glad to join this webinar. The formal title for the webinar today is Reimbursement as a Driver of Valuation. The more important title is the next line. It's actually understanding why developing reimbursement strategy is a critical function for medtech companies. Before we start, just a few words about Boston MedTech Advisors. We started about 19 years ago. We worked already with over 400 companies in all areas of medical specialties. This is a partial list, which I won't get into the details right now. The more important thing is to understand that what we are doing, because that will create the context for this discussion today. We are supporting companies to introduce, that are trying to introduce new companies, that are introducing new technologies. More important, we also work with them on increasing the likelihood that the technology would be adopted. And I'll talk about this in a few minutes. But to get adoption, companies need to understand not only the technology and the regulatory part, but they need to understand how the technology will fit in the marketplace. They need to understand the drivers for adoption, which include reimbursement, clinical evidence, workflow, and so on, and understand the barriers for adoption. There are many factors that affect those things, and they're all intertwined. After that brief introduction, let's jump right away to the agenda today, which is a fairly long agenda. I'll touch on a number of issues here. One is I'll talk a little bit about what I consider to be business realities or explain why reimbursement is even important for early stage companies. Then we'll talk a little bit about codes and coverage, the very basics. Then we'll explain how money flows to providers in that market. And then we'll move to talk about the changing landscape of reimbursement in the US. And following all of those discussions, what does it all mean to companies that are developing new technologies? And if we have time, we'll touch also on a couple of case studies. So business realities, or why reimbursement is even important. So every company that develops technology, develop a business plan that has something that looks like the blue line, essentially suggests that at a certain point of time, they introduce the technology And after a reasonable period of time, the technology gained adoption. And what is adoption? Adoption is a state where, or a time where a subset of the market is using the technology on a regular basis. It's beyond being an anecdotal use by providers. The reality is that the vast majority of technologies that are being introduced to the market never reach this blue line or something similar to this. They are much closer to the green line. The technologies never reach adoption. They remain episodic or even worse. There's a small subset of technologies, less than 10%, that gain market adoption. And generally, it takes them longer to do this than had been anticipated early on. So I often talk about what I consider to be the adoption paradox, which is the need for new technologies is increasing all the time, but yet it is increasingly more difficult to gain clinical and market adoption. So we have a schizophrenic approach here to the market. The market needs technologies, but creates many barriers to adoption. If you look at the blue line as a blue arrow, it depicts the time to market. And the time to market has increased over the years, over the last 20, 30 years, somewhat. Time to market is from the moment we start developing the technologies until we get FDA approval to be on the market. To do this, we need to demonstrate safety and efficacy, and because technologies and applications are becoming more complex, then demonstrating efficacy takes longer. The dramatic change is the time to adoption. If we go back to the late 90s, you can see that the time to adoption was short after time to market. If the technology worked and we had a sales force and we had some data that demonstrates that we get appropriate results or outcomes, then people started to use it. Providers started to use it, hospitals, clinicians, physicians, and so on. And then gradually we have seen more and more barriers or more and more elements that require to meet adoptions being introduced. Reimbursement is obviously a big part of it. And not only that the barrier to reimbursement has been introduced about 20, 25, 30 years ago, but the bar for gaining reimbursement, the requirements are getting larger and larger. Outcome data, if we needed to demonstrate some limited data, now we need to demonstrate multiple studies on larger populations, followed for a longer period of time before clinicians are ready to use them. And it's not only to have reimbursement and to demonstrate outcome, we now, more and more providers want to see comparative assessment data to see how our technologies compared to other methods, especially considered to be the gold standard or the established practices. Another way to look at the dynamic on the market is a famous Moore chart that shows that companies' products can introduce market. Initially, they appeal to the innovators or to the early adopters, but at a certain point of time, they hit a chasm. And in our business, in the healthcare business, the chasm is really represented, or to overcome the chasm, we need to have significant amount of clinical evidence, and we need to have reimbursement for the vast majority of the technologies in order to reach the main market. So the longer time to adoption has considerable business implications. It delays the revenues. It means that we need to have more funding rounds. The valuations are negatively impacted in the early rounds because investors know that we'll need much more money and it will take longer. Business development initiatives, the strategics, and so on are sitting on the sidelines until we can demonstrate some market adoption. And during that process, we have increased risk of new competitors and new methods, new technologies introduced to the market and replacing what is it that we are offering. So reimbursement is a key to market adoption. And the question is, what does it mean to have reimbursement? It means a number of things. The technology or procedure is covered by payers. The coverage, not only that they provide coverage, but the coverage is sufficiently broad. It's applicable to a sufficient number of patients. It's not overly narrow. And the payment offered by or agreed to by payers is appropriate, which means it has to cover the cost of the physicians, the hospitals, the whole provider chain, the distributors, and the manufacturers. Everyone has to get a piece or is receiving a piece of that payment. It is important to recognize that favorable reimbursement doesn't guarantee utilization of the technology. There are many, many products and services that have very good reimbursement and no one is using them. But the opposite, we have to recognize that lack of reimbursement generally will impact utilization and will impact it adversely. So let's jump to codes and coverage. So actually the word reimbursement is an informal terminology. The formal terms that are being used in the industry are codes, coverage, and payments. The codes are really identifiers of procedures and devices. It's just a way to represent in a number of digits, typically 5 digits, what is that we have done as providers. The codes are universal. The entire industry, all payers, all providers are using the same set of codes. Coverage defines the terms and conditions for payment. Each payer generates a coverage policy for every procedure. So now we are moving from universal to non-universal activities. The payments is how much is actually being paid by the health plan. And that one is even less consistent because it's not only payer specific, it's very often also provider specific. Payers will negotiate with the payers how much they are going to pay for different services. Codes, there are lots of codes and there are different sets of codes. And I'm not even going to cover everything. I'm just going to talk about the major categories of codes, terms that probably most of you or all of you have heard before. Starting with the ICD code, standing for International Classification of Diseases. There are, as you can see, about 70,000 codes that describe different diagnoses, essentially conditions or medical conditions of patients, and about 70,000 type of procedures being done. The ICD-10 are published by the World Health Organizations. They are used in all insurance claims. Every insurance claims have to describe the appropriate ICD-10, which suggests what is what is the reason we provided a service or gave a product to a patient. The ICD-10 by itself doesn't define payment and doesn't define coverage. It's just a description of a procedure or a diagnosis. DRGs, they're used codes, set of codes that are used for inpatient care in United States. They stand for diagnostic related groups. There are over 700 groups. The DRGs are actually standardized or defined standardized prospective payments. Prospective means a priori, the hospital knows how much they'll receive for caring for a patient based on the principal diagnosis of the patient, the procedures, the principal procedures that is provided to the patient, the surgery, ICU, etc., and the comorbidities of that patient. So it's a complex, very complex formulas, but the important thing is to know that the DRG, the payments to hospitals are not based on the actual cost of treating a patient, but on an average cost for that DRG. The other important thing to understand is the DRG payments cover all charges associated with an inpatient stay, everything, with the exception of payments for physicians. For those that are here from non-US companies, this is different. The DRG is very common now in many of the European countries and other countries around the world. But in most countries, the physician payments are included as part of the DRG. That's not the case in the United States. The other set of codes, Healthcare Common Procedure Coding System, pronounced HCPCS, when we want to abbreviate it. Those codes describe, there are multiple groups of HCPCS codes, but generally they describe items, supplies, products, and non-physician services that are not covered by payments for other services. So if an X-ray or if a medication is provided to a patient inside while he's in the hospital, then that medication is covered through the DRG. If it's provided to a patient outside the hospital, then it would be covered based on the HCPCS code assigned to that medication. HCPCS codes are maintained by Medicare, but they are used by the entire industry. They're updated very often, quarterly. And as I mentioned, there are different groups of codes. This is just a partial list that you have there for supplies, durable medical equipment, drugs, lab services, etc. There are all kinds. There are about 15 different code groups. CPT, very important. They're used to report medical, surgical, and diagnostic procedures and services provided by physicians or other qualified healthcare providers, whether those services are provided for inpatient or for an outpatient. Once a physician or a qualified healthcare provider provides a service, they use CPT to describe that service. There are over 10,000 CPT codes. They are maintained by the American Medical Association, again, used by the entire industry. Recent initiatives for new codes include remote monitoring and therapeutic services, digital services, AI-based technologies, software-only devices, etc. So the AMA, when they see developments, requests for codes in new categories of products based on new technologies, they try to put all of those things to create a structure for those codes. There are two primary categories for CPT codes. Is category 1 and category 3. I'm skipping category 2 because it's insignificant. Category 1 is the primary CPT code. So those are the permanent codes. Obtaining a category 1 requires the applicants to meet significant requirements, including, this is not a complete list, but including there need to be multiple publications, published papers describing the use of that technology. At the time of the application, there need to be already an active user base for the technology in the US, and there need to be support of the respective professional societies. The important thing to understand is while a category 1 is issued, reimbursement is not guaranteed, but it's more likely by most payers because there are so many requirements for getting the code. In most cases, it will also satisfy, not always, but in most cases, it will satisfy the requirements of the payers. Category 3 was assigned or was formulated in order to help companies introduce products and start developing reimbursement before they meet the requirements for category 1. So it's typically assigned to emerging technologies. They are defined as temporary codes. They can be used up to 5 years unless they are replaced earlier by a category 1 code. So the expectation is that category 3 would be there in the beginning. And once the company or the sponsor can meet the requirements for category 1, then the category 3 is deleted and category 1 takes over. Category 3 provides a mechanism for reimbursement, but even if it's reimbursed, it will generally be limited coverage. And the reason is that there's limited evidence at that point of time. Payers are more careful whether they want to cover it or not. Yet, most new technologies today start with category 3. It takes generally years to get to the requirements for category 1. So meanwhile, most companies found out that they are benefiting by having a category 3 to start with. I'm not going to go through all this chart, but developing a category 1 is a long process. It takes about 2 years from the start to end, if everything goes well. Category 3, if you just look at this chart, category 3 essentially is only the top third. The process for category 3 and category 1 initially are very similar. The requirements are different, but the process is similar. But once we are done with the gray blocks on the top, category 3 could be issued. Category 1 at that point will take at least another year. Coverage. Code doesn't imply coverage, 2 different things. Also, FDA approval doesn't guarantee coverage by payers. Some people are surprised once they get FDA approval to find out that payers expect FDA approval, but it's required and completely insufficient to issue reimbursement, to initiate reimbursement. The reason is that FDA approval is intended to allow the marketing of the product. Payers say you can market it, but that doesn't mean necessarily that we should pay for this. We have to decide whether to cover the device or the respective procedure. Respectively, FDA approvals require demonstration of safety and efficacy. It's a very objective, based on scientific data. Payers' coverage decisions assess clinical outcomes. It's a very subjective process, and it's essentially interpretation of the strengths of the clinical information. How do we know it's very subjective? We present, I mentioned before, that coverage, every payer will determine their own coverage policy. We can present the same evidence to 3 different payers, and one payer will decide to cover the new technology. Another payer will decide absolutely not to cover. They'll consider it to be still experimental from their point of view, not from regulatory point of view. And a third payer will decide to cover, but very, very narrowly, maybe after everything else has failed. Medicare as a payer, we'll talk about Medicare, versus all the rest. Medicare coverage decisions are governed by law, by statute. And the statute states that reasonable and necessary that Medicare has to cover everything that is defined as reasonable and necessary for the diagnosis or treatment of illness or injury. It's a very broad definition, and like every law, there are lots of regulations and interpretations that have been developed over the years by CMS to try and explain what that means or define how their interpretation of the law, and that keeps changing all the times. The important element here is to understand that the law doesn't allow Medicare to consider the economics of the product in their decision. Their decision has to be based on this reasonable and necessary definition, at least not formally. There's as the head of the coverage group within Medicare one time, he said, David, we're in Washington. We have Chinese walls between us and the people that deal with the money in Washington. Everyone else, other than Medicare, can set their own criteria for coverage. And generally, they look at or try to assess whether the new technology or the new procedure improves health outcomes, and how is the new technology or the new procedure vis-a-vis the established alternatives. Everyone else but Medicare will consider and does consider the clinical elements and the economics of the procedure at the same time. But when they publish their decisions, they'll never talk about economics. If they don't want to decide to cover something because of the economics, they'll always find that the clinical evidence is insufficient. So how is the money flowing to providers? First, a few numbers. United States spends about $4.5 trillion on healthcare each year. That translates to almost $14,000 per person, every single person in the United States. But the numbers are not consistent. Obviously, they change by age, they change by medical situation, and they change by geography. Utah, for example, is the lowest healthcare market in the United States, and the average cost in Utah is a little bit more than half of the national average. So obviously, there are states that are much more expensive than this number that you are saying, than the $13,000. Who is spending the money? Federal government, state and local governments spend a little bit less than half of the money, and everyone else, businesses, individuals, any other sources, private sources, spend a little bit more than 50% of that money. So if we take a very high level view of how insurance is structured in the United States, there are, in the middle, there is a public insurance, which is government, federal government, or local state governments. There are private insurance on the left side, and there is a group of uninsured in the United States, which is hovering around 10% of the population. So the three different categories, the largest three categories. One is Medicare. Medicare is a federal program. So that means it's managed by Washington, D.C. It's standardized for everyone that is covered by Medicare. And those are everyone that is over, almost everyone in the United States that is over 65 years old. And those are younger, but to be permanently disabled. They can be covered by Medicare at a younger age. Overall, Medicare covers a little bit less than 20% of the population. About 40% are now covered through plans called Medicare Advantage, which is essentially, rather than Medicare covered directly the patients, Medicare Advantage are plans offered by commercial payers to Medicare beneficiaries, but rather than the patients or the beneficiaries paying the premium, Medicare essentially takes the money that they allocate for that individual and tells the commercial payer, we'll pay you and you cover that individual. The Medicare Advantage plans have to cover everything that Medicare is covering, but they have the latitude to cover additional things if they want to. So Medicare Advantage actually is growing fairly rapidly. It'll probably be within a number of years, it would be the majority of the patients. The government is pushing real hard to transition patients to Medicare Advantage plans. Medicaid are plans administered by states. So there are 50 Medicaid plans in the United States. Each state has its own plan. They're intended to cover the lower income population who who is entitled to be covered is defined by each state, and each state also define what they cover for those people. There's a special program for children that don't meet the general criteria for Medicaid, but are not covered by their parents' insurance for one reason or another. For example, maybe their parents don't have insurance, so the government, the local government of the states will cover the children. Overall, Medicaid covers about 25% of the population. It's a very sizable portion. And all the rest are commercial and private insurance plans. The majority of them are funded by employers. At least the majority of the insurance is funded by insurance. And others that don't work in a place that provides health insurance, they need to get their own self-insurance. And as I mentioned, about 10% of the population, 10% of the people in the United States don't have any insurance. So you have here another more detailed breakdown of who pays. You see that Medicare and Medicaid, the numbers here are not consistent. They're taken from different sources, but I'll focus on the right curve, which is important. It demonstrates what was happening in healthcare in the United States. If you look at the period 1960 to 1980, the expenditure of healthcare in the United States moved from essentially tripled every 10 years. And since the 90s, which was when managed care was introduced in the United States, and today almost over 95% of the population in the United States is covered by one version of a managed plan, managed healthcare plan, one of the types, one of the categories. They slowed down the increased cost or the increased expenditures, but they're still ramping up fairly quickly. And you can see that from the 90s, the healthcare costs essentially have doubled every 10 years. How is the money being spent? There are lots of different facilities. There are community-based healthcare, there is acute care hospitals, there is long-term care or post-acute care. And there are many more types of providers that even shown in this little chart. But generally speaking, hospital care, hospitals are receiving about 30% or consuming 30%, a little bit more than 30% of all the healthcare expenditures in the United States, over about almost $1.5 trillion. Professional services, those are all the physician offices and related home care. You can just go through the list and see. This multitude of payment systems, multitude of considerations, lots of providers, physicians being paid separately than hospitals, et cetera, makes the whole system very complex. And as was quoted by Dr. Ezekiel Emanuel, who was one of the architects of so-called Obamacare, Affordable Care Act, that was legislated about 12 years ago. He said the American healthcare system is a patchwork of different arrangements, very confusing to navigate. And that's a very, very modest understatement describing what's happening in the United States. Just a word about how manufacturers of medical products being paid. In most cases, they don't bill insurance companies. They go through distributors or sell directly to any one of the providers. It could be hospitals, it could be nursing homes, it could be physician offices, etc. Those people use a product and then bill insurance plans. The insurance plan provides them, they submit claims, they receive money from the insurance, and part of that money is then flowing back to the manufacturers. Is reimbursement environment finally changing in United States? Maybe, and maybe instead of writing maybe, should write now likely. So first, again, few numbers. United States spent over 18% of its GDP, gross domestic product, essentially almost 1/5 of the economy is devoted to healthcare in United States. And you can see the increase here over the years. It continued to go up and up and up in spite of all the effort to curtail this curve. Just for comparison, the second highest or the second most expensive healthcare market in the world is Germany, and they spend less than 12%. And the average for OECD is less than 10%, is about 9.5%. Israel, for example, is spending about 7.5%, less than half of what United States is spending. Not only that United States spent a lot on healthcare, which is really a macroeconomic factor, but it translates to every individual in United States. If you look at the inflation over a 20 years period, you can see what happens to healthcare expenses versus other sectors in the industry or in the market. I'm sorry, food, apparels. We know that electronic software is going down, or the unit cost is going down, while the healthcare continued to go up. And that translates to everybody's pocket, even when people are insured. Sorry about that. If you look at the chart below, you can see what happens over a 10-year period to overall inflation. That doesn't include, obviously, the last year, but overall inflation during that period of time was 17% over a 10-year period. Workers' earnings essentially were slightly better than the inflation. They were able to move ahead a little bit. But if you look at the out-of-pocket expenses in the United States, you see that they increased about almost 10 times than the growth in earnings. So what's happening is, as healthcare becomes more and more and more expensive, the insurance companies are pushing more and more of the to individuals. So even though the average expenditures for everyone in the United States is over $13,000 per year, most people that require medical services will spend number of thousands of dollars a year out of pocket. So what are the current or the old payment structures? They're all based on volume, essentially pay for every service that is being done, providing most of the structures provide incentives for physicians and hospitals and other caregivers to provide more and more care. Essentially, there are, if we look at the structures, there are fee for service, there are fixed price, we're going to pay you X like DRG. There are some still cost plus, it costs you $100, we'll pay you $105, or we'll pay you on a per diem basis. All of those structures reimburses providers for what they're doing, but they don't provide any incentive for the providers to be efficient with what they're doing. They're actually being penalized by being efficient. Or there are capitation structures. Essentially will pay you X amount of dollars to manage certain population. And you have to manage that population with the money that we are giving you. It's essentially an incentive to do less, but there's no incentive to maintain quality. Actually, there is inherent incentive to reduce quality in order to save money. So there is a shift that has started about 10 years ago and is evolving. It's in process, but it will take many more years to move through and be fully implemented. And this is a shift from volume-based payments to value-based payments. And if we look at what the CMS has defined, as they said, we are moving to a system that rewards value over volume. And they expected that paying for value will foster innovation as providers look for ways to compete by providing the highest quality care at the lowest cost. And almost every company that we are talking to at these days said, you know, whatever we are providing right now, whatever we're developing is intended to improve care and do it at a lower cost, almost everything. So developers of technologies are catching up to this drive. What is the value-based payments? Value is measured by patients' health outcomes per dollar spent. Now, we can measure cost. It's not trivial, but it's relatively easy to measure cost, how much is being spent on caring for a patient. It's much more difficult to measure quality. But without measuring quality, we cannot define value. So the industry is coming with many definitions of quality or quality improvements. And for different services, for different patients, for different disease states, they're using different measures. The important thing is to apply measures in order to be able to create value. As a result of all the shifts, there are many programs, plans, initiatives that are being developed. This slide just lists some of those names. There are lots and lots of different acronyms for those things, but some of the more famous programs and initiatives are accountable care organizations, value-based purchasing programs, reduced payments or no payments for hospitals for acquired conditions. Think that patient enters a hospital because they had pneumonia, and while he was in the hospital, got also pressure ulcers. So in the past, hospitals were paid also for the pressure ulcer because it was a different condition. Today, if it was acquired while the patient in the hospital, there is no additional payment. It requires a hospital to really take care of patients. Hospital readmission reduction program. Before, it was a revolving door in a way. A patient was discharged from the hospital. There was an incentive because of the DRG payments. There was a strong incentive, there is strong incentive to discharge the patient as early as possible. If the patient is not ready to be discharged or is not managed properly after being discharged, it is more likely to return to the hospital. Until a few years ago, hospitals didn't care because when the patient was readmitted again, he was discharged after having chronic heart failure, and he had over his accumulated fluid that had to be removed from the lungs. He was discharged, and then if he came back 2 weeks after that with a similar problem, for the hospital was another DRG payment. Now the payers are telling the hospitals, no, if the patient is returning within 30 days, then you're not going to be paid again. Consider it to be the same admission. So the landscape is changing. In the past, all the payments were volume-based, or most of the payments, and today, as I mentioned, they are value-based. Fee-for-service is replaced by bundled care. We are paying not for every element, but for the entire episode. Payers assume financial risk and now payers and providers share risks, financial risks. And as a result of all of this, if before hospitals let physicians, surgeons select the devices that they want to use, now it's always a system decision. So there's no one physician that can decide what is that he's going to use. Everyone is involved in that decision. So what is that we need to do as a developer of technologies? As I mentioned before, reimbursement affects lots of different things, and really the success of the enterprise. Go-to-market strategy is impacted by the lack or the availability of reimbursement and the scope of coverage. Sales are difficult to ramp up until reimbursement is established. Marketing partners, strategics, and acquirers hold off getting involved until market adoption is demonstrated. And in the process, investors want to know early on what it will take in terms of time and funds to obtain reimbursement. So companies that are developing technologies need to assess what is the likelihood of developing reimbursement and what it will take. And there are many factors that have to be assessed. You're seeing here some of the key ones. Are we making changes to the medical practice? Who will be the users? Where will the service be used? What will actually be reimbursed? And who is going to pay? And those considerations, as well as other considerations, are all important. You cannot really figure out what is the status of your reimbursement without understanding all these factors. So the first question that everyone has to ask is, when we introduce the new technology, can we use the current codes and the coverage policies for this technology? If yes, great. If not, then we need to understand early on the optional strategies and develop the roadmap that will lead us to reimbursement. And why do we need to develop this roadmap early on? It's because reimbursement plan will affect all other key activities that are happening even before we reach the market. It can affect the actual product configuration, absolutely the regulatory, absolutely the clinical studies and the clinical evidence that we need to demonstrate, and how we approach the market. All of those things are going to be affected by that roadmap. And if we don't have the roadmap, we don't know if our product is designed properly. We don't know if we are pursuing the optimal regulatory clearance. We don't know if we are performing the optimal clinical studies, etc. So failure, we are being asked all the time, when should we start reviewing reimbursement? Every startup company asks this question. And as I just said, the failure to understand early in the project lifecycle the roadmap to reimbursement has implications. Yesterday, in the past, it was actually not a big deal, not dealing with this right away. But today, it's absolutely a business malpractice. And the sooner a company develops a roadmap to reimbursement, the better this company is going to be. So just a couple of case studies, quickly, two companies that we were heavily involved with. Both are publicly traded. One was publicly traded. And so a lot of the information here has been published. First company is Itamar Medicals. They developed a very innovative technology for performing sleep studies at home, something that is different than any other technology called WatchPat. And initially, it was very innovative and as such was not covered by anybody. We worked with that company to first create an initial market for this within provider systems that are relying on reimbursement from third-party insurance plans. And we focused on the VA and Kaiser Permanente. That enabled us to establish the first market. I mentioned before, the go-to-market strategy is always affected by reimbursement. So that's an example. As we start to gain adoption in those healthcare systems, we approached CMS before we had CPT codes, because we didn't meet all the requirements for CPT codes, and we convinced them, it took about a year, to issue coverage for Medicare beneficiaries prior to CPT codes. There is a mechanism to do that, or there is a pathway to do this in specific situations, and Medicare went along with this. They issued a HCPCS code, or G code, which is in lieu of CPT code, which was gradually adopted also by commercial payers, and that help us to expand as the payers adopted the code and started to issue coverage for the watchbed that enabled to expand the market for the watchbed. Subsequently, CPT codes were issued and the coverage expanded that enables a company which had minimal presence in the marketplace to start building the market, accelerate the growth. They reached about $50 million in run rate revenues, demonstrating continuous growth of about 30% over a number of years. And that led about a year and a half ago, 2 years, to acquisition by Zoll Medical, Boston-based company, for $500 million. Second company, very innovative company called NovaCure. They developed a totally new treatment modality for malignant tumors, solid tumors. It's based on applying low-intensity electrical fields that are applied continuously into the tumor. The first application was brain cancer, glioblastoma, and they're in the process of pursuing additional tumors in the abdominal and the chest. There are many studies that are undergoing right now. This company came to us to understand how they price a technology that is totally different for this application for cancer, and how to structure reimbursement for something of that nature. And in that case, we decided, the company, to do something that is very untypical, certainly in the cancer field, and become the provider of the therapy rather than sell the devices to oncology clinics or to hospitals. There are multiple reasons for this. I won't get into all the rationale at this point, but company adopted that strategy, which was 180 degrees from what they planned to do originally. Subsequent to this, they're able to receive a code for the equipment, including the clinical support for the equipment. They're being reimbursed. It's an ongoing use of the product, essentially from the moment the patients start using it until they perished, actually. They are receiving, the company is receiving over $10,000 per month for each patient. So even though the only approved application for them at this stage is brain cancer, which is one of the smaller cancers, they generate revenues of over $500 million, and their valuation, their publicly traded company, is it's over $8 billion now. So with this, I'm ready to take questions.
Thank you so much, David. It's a very heavy topic, and it was always fascinating to hear that. We have only 2 questions. One is very general. Are we going to send the slides and recording? And the answer is yes. Yonat Harel Price is asking, what insurance plan do HMOs and IDNs usually accept, whether private or other? That's for you, David.
So HMO, the terminology here is problematic. So HMO is a type of plan offered by almost all insurance companies. It's their HMO, PPO. There's a alphabetic soup of acronyms for different plans. Every insurance company will have multiple plans. One of them, or some of them, will be HMO. It's essentially the way they structure the plan. In most cases, patients can go only to limited panel of providers. So the right question, or the way to address or to answer this, if I understand correct the question, is providers that are part of the panel of a specific HMO can bill for the services that they provide to the patient that have that HMO plan. If a patient goes to a physician that is not part of that panel, they have to pay separately. So, the plan will not cover it. IDN stands for Integrated Delivery Network. And again, there are different forms of integrated delivery networks. But if we look at the largest one and the famous one, Kaiser Permanente, generally speaking, IDN stands, the idea of IDN is that they are both the insurance and the provider. So it's a closed economic systems. They don't submit claims to Medicare or to Blue Cross. If I'm a member of Kaiser, I'm paying to Kaiser and receive all my healthcare through Kaiser.
Yonah, did that answer your question? You can unmute.
Yes, thank you. Thank you. It was great. Thank
You're not, if you want to further discuss it or more specifically, I'm happy to do, we can do it offline.
you, David. It was very good talk also.
So the last question from Christine Rohan, and she's asking, in your experience, will providers adopt novel technologies for QI purposes and reimburse adjunctive to clinical care ahead of FDA reimbursement?
Ahead of FDA reimbursement?
Ahead of FDA reimbursement.
So what is the application? What is the technology used for?
Christine, please go ahead and unmute.
Yeah, it's improved risk prediction for postpartum hemorrhage. So it's used alongside the current surveys.
So generally speaking, the answer is no. When a technology doesn't have FDA approval, it cannot be on the market. If it does, it's not on the market, then payers are not going to use it. There are some exceptions. Medicare, for example, has the ability in some cases to reimburse the cost of technologies for products used in clinical studies. So that's the exception. That's for technologies that require FDA approval. It's different. There are technologies that don't require FDA approval, and that's different steps, different situations. So I'm not sure exactly what is that you're doing or planning to offer, but again, I'm more than happy to discuss it offline.
All right, thank you.
Thanks, that there's no more questions. Thank you so much. Fascinating as always to meet you all and to listen to you.
Just thank David and thank everybody for joining us. Have a great day.
Bye, guys.
Thanks, everybody.
Bye-bye.
Thanks, everyone.